96.3 FM, The Source.
All right, one of the benefits of doing a radio show is you get to talk to experts about things, and when those experts are doctors, then a lot of times those things that you benefit from, the information actually applies to yourself or somebody you care about. So let's see if that applies here. Dr. Seth J. Baum is on the phone. Dr. Baum is the president of the American Society for Preventive Cardiology, and Mahabir is on the phone, a PCSK9 inhibitor patient, a high-risk cardiovascular patient. So we're going to learn something because I don't know what PCSK9 is. We'll find out right now. Dr. Baum and Mahendra Mahabir, good morning, and I hope I said your names correctly. Good morning.
Good morning. You did great, actually, on all of them.
Okay.
Excellent. Good morning. How are you?
Good. Oh my gosh, your voices are similar. This is going to be hard to figure out who's who. Dr. Baum, what is PCSK9? What is that?
So it stands for proprotein convertase subtilis kexin type 9. It's a big name, so that's why we call it PCSK9 inhibitor. But what it is the inhibitor is a human monoclonal antibody. So it's an injectable drug. It's not a pill. And it blocks a certain protein that then ultimately leads to a significant lowering in LDL cholesterol, or the bad cholesterol.
Okay, and is that way of lowering bad cholesterol the only way we have? Is it the best way we have? And why do we need to lower the bad cholesterol?
Yeah, so those are all great questions. So let me start with the last question. Why do we need to lower it? It's because over the last 30-plus years, we've actually proved that LDL cholesterol causes heart attack and stroke. And we know how prevalent heart attack and stroke is in the United States. So we have something we've identified, LDL cholesterol, that definitely causes heart attack and stroke. And lowering LDL cholesterol lowers the risk of heart attack and stroke, so that's why we have to do it. The mainstay of therapy, however, there are two things. One is we use therapeutic lifestyle changes, meaning we always encourage our patients to have an optimal diet, keep an optimal weight, and exercise regularly. But if a patient needs, because of risk and because of LDL levels, a drug, we start with statins. Statins are the mainstay of therapy from a pharmaceutical standpoint for LDL lowering. They've been, we have 30 years of information on them.
Right.
Now, there is a group of patients, though, in whom statins are not enough to lower LDL cholesterol. So they're valuable, and they're good, and they're important, but some people need more. These are higher risk patients. And PCSK9 inhibitors were developed and approved by the FDA in the summer of 2015 for such individuals. I will tell you that last year there was a clinical trial called the Repatha Outcomes Trial that proved, in 27,500 patients, that Repatha lowered the risk of heart attack, stroke, and coronary revascularization in individuals with established cardiovascular disease, enough to have the FDA change its indications for the drug.
Mahendra, were you part of that trial?
No.
No. Were you having symptoms that did you go to the doctor? Were you feeling ill? Did you have a heart attack, or did you have a family history of heart attacks?
Well, let me give you a little bit, a quick synopsis of my history. 47 years old now. My coronary disease started roughly about 17. From then to now, I've had 4 heart attacks. I've been ballooned 4 times. I have 7 stents placed.
Oh, my gosh.
I have 5 arteries bypassed. And
wow.
I've went through 10, 15 years of statin drugs, have been put on a combination of different things and never could get my levels to where it needs to be or at a certain point. Now, 2015, when PCSK9 came out and was approved by the FDA, my doctor prescribed it for me, and I was denied. I thought I was the perfect candidate. My cardiologist thought I was the perfect candidate,
right.
And we went through months and months of denials and reapproval process, which that's why I'm here today, trying to bring light to it, because it hasn't gotten that much better, and
oh, really?
It's a problem.
So why were you denied? I'm not sure I understand that.
Correct. I was put through a bunch of different process to go back, take backward steps, go back on statins, which I've already done for 10, 15 years, and shown that it's not bringing me down to a level that I need to be. If I could, I'll pass it on to Dr. Baum.
Yeah, I could put this in perspective for you. So Mahendra is not your typical patient. He has familial hypercholesterolemia, but a very severe form of it. Familial hypercholesterolemia is a genetic disorder of LDL, raising LDL, and it's very, very common. His form is more severe. His LDL, the bad cholesterol, was over 400. Okay, and on therapy, on maximally tolerated statin therapy and everything else available, it was 200. So, to have him denied, he's one of the reasons I became so active in this process. It's absurd. And the reason he was denied is that the insurance companies would push back and say, he hasn't done this, he hasn't done that, whatever. Let me tell you what it took to get him approved.
Oh, okay.
We went to Gina Colada of the New York Times. We had an article written about him, and the next day he was approved.
So, so it's got to be money. It's got to be, is it expensive?
It depends how you define expensive. Yes, but I would say yes. The drug's a costly drug. It's a human monoclonal antibody made by immortal cell lines, so it is expensive. But it also has been shown to decrease heart attack and stroke. So,
did your efforts to get Mahendra treated properly, did that spill over to the rest of us? Is he like the trailblazer, so that those of us who need this will be able to get it now?
So there are a lot of trailblazers, and we still are fighting this fight. The American Society for Preventive Cardiology has had town hall meetings at major meetings across the country since 2016. We're going to continue through 2018. We have a mobile app coming out on Sunday to help access. He has helped, and trailblazers have helped, but sadly, the denial rate in commercial insurance is still 70%. 70% denial. Oh,
my goodness. Okay.
And doctor, you're going to be speaking at the annual scientific sessions about this?
So I have a poster that demonstrates several things. One of the things it demonstrates is it doesn't really matter how sick you are, really, with regard to approval or denial, and many others have shown this as well. In other words, it almost looks like the flip of a coin. The other thing is the event rate, how frequently people have heart attacks and strokes and coronary revascularizations. That event rate in individuals denied therapy is actually higher than the group of patients who have asked for the therapy. In other words, the sickest patients are being denied, those who have the highest events. So we've shown that of these people, 110,000 events can occur in a year in that denied group.
And do you have any children, Mahendra? And if you do, are you afraid that they might have what you have?
Well, I do have a son, and he's 20 years old now, and my heart disease is genetic, and he does have it, and we've known about it since he was about 8 years old, and started the traditional route of healthy diet, exercise, and worked our way up. That's one of the reasons why I'm here, is to bring awareness. So because it's genetic, when it's his time, hopefully some of or all of these issues are worked out, where because there are things that can keep him from having a heart attack and or getting to the point or going through what I've gone through, is why I'm here. Hopefully we don't have to for many, many people who need it.
Well, thank you for the work you're doing, both of you. I think you're showing some light on something we need to pay attention to. Real quick question, Doctor. Does the PCSK9 inhibitor, does it reduce, or let me ask you this, when it lowers the cholesterol, does it improve the health of the heart automatically, and or maybe even reverse whatever problems might have been caused earlier?
Right. So a very large trial, 27,500 plus patients, was completed last year. It was called the Repatha Outcomes Trial, or FOURIER. And that showed that in individuals with established cardiovascular disease, the drug in just a little over 2 years statistically significantly decreased the risk of heart attack, stroke, which is not insignificant, and the need for coronary revascularization. So that's called an outcomes trial. And so, yes, it definitely has been shown to decrease these events. And again, the FDA saw that, and they changed the indications for the drug in December of 2017.
All right. I know you have to run. Thank you for doing this. Do you want to leave us with a website?
Yeah, I do, actually. So the ASPC is going to have a mobile app that you can get in the App Store as of Sunday. A couple of websites would be aspconline.org, but also look at the FH Foundation, Familial Hypercholesterolemia Foundation. Go look for them online. They have great resources. And one final one is an advocacy group that's doing tremendous work. It's called PACH, P as in Peter, A-C-H as in Harold.
Dr. Seth Baum and Mahendra Mahabir, thank you both for being on the show with us. Good luck, Mahendra, and keep up the good work, Doctor. Thank you, guys.
Thank you.
We'll be right back.
Say, if you're looking for what's really new and different for your yard or garden this